We are live.
So, good morning, everyone, and we welcome you all to the AIOS International Ophthalmic Conclave 2024, which has the best of ophthalmic knowledge from across the world, curated for you especially by the All India Ophthalmological Society and Dr. Santosh Honawar. I'm Dr. Rituja Thomas, and I'll be your host for this session on ocular surface. And I invite the moderators of our session, Dr. Jayesh Vazrani from Ahmedabad, India, and Dr. Abha Gaur from New Delhi, India, who will introduce the chairperson and the faculty and initiate the session. Over to you, Dr. Abha and Dr. Jayesh.
Right. Thank you, Dr. Thomas, and welcome everyone to this wonderful session on ocular surface disorders. The chairperson for today's session is Dr. Virender Singh Sangwan from Dr. Shroff's Charity Eye Hospital, Delhi, where he is the Director of Translational Research and Director of Innovations. So he'll just tell us a little bit about the outline of the program that we have lined up before us, and then we'll start the presentations. Dr. Sangwan, please.
Yeah, thank you, Jayesh, and thank you, Dr. Thomas. The today's ocular surface conclave on behalf of AIOS is a very interesting program, and the lineup of the speakers we have is practically a galaxy of speakers from across the world. We have Professor Jodh Mehta from SNAC Singapore, and we have Professor Harminder Dua from UK. Professor Pinita Prabhaswat from Thailand, and Professor Guillermo Amasqua from Bascom Palmer, USA. All of them are pioneers and legends in their own respective field within the ocular surface. So we will have a very interesting sort of a session, and I hope that it will be very educative, since they bring a lot of experience both from clinical and research side. And our moderators Jayesh and Abha will make us all align to the program and keep us on time. We will have at least Professor Mehta and Professor Dua for Q&A around 1 o'clock, so we can keep our question answers or time accordingly. So thank you very much and enjoy your session, and very happy Republic Day to all of you. Over to you, Abha and Jayesh.
Thank you, Dr. Sangwan. So we will start with Dr. Jodhbir Mehta's talk on vernal keratoconjunctivitis. And just a small introduction, Dr. Jodhbir Mehta is the head and senior consultant in the External Eye Disease Department in the Singapore National Eye Center. So he has sent us his recorded talk, and he will be joining us sometime later. I'm just sharing his talk. Can you all see the screen?
Yes, we can.
Good afternoon. So first of all, I'd like to thank the organising committee for this kind invitation to talk at AIOS. I'll be talking about vernal keratoconjunctivitis. These are my financial disclosures. I don't have any disclosures pertaining to what we're going to be talking about today. So vernal keratoconjunctivitis is really a form of hypersensitivity disorder that manifests itself as an allergic eye disease. And it is one of many allergic eye diseases that you all be familiar with, including atopic keratoconjunctivitis, all the way down to seasonal allergic conjunctivitis. And it really can be considered to be one of the more severe variations of allergic eye disease. Of course, we know that it's basically immune mediated in the early type. It's mainly associated with histamine release, and this is basically performed basically by mast cell degranulation and the secondary recruitment of inflammatory cells. In the late stage type, it basically involves the recruitment of eosinophils and T lymphocytes, and these will basically be the effectors of some of the manifestations of the clinical symptoms that we see in patients with reactivation of their VKC. When we consider looking at treatment options, the conventional treatment starts with oral antihistamines or topical antihistamines, and is basically increased into topical steroids, immunosuppressive agents, and then more systemic medication typically steroids or other immunomodulators, and lastly, surgery to deal with some of the manifestations that we basically see clinically. And it's really a stepwise approach, escalating if there's no improvement over a 2 to 4 week time period. I'm just going to show you this case as an illustration. It's a 14-year-old Singaporean girl that we saw at SNEC. She had episodes of itchy eye throughout the year. She was struggling at schoolwork. So this is a common thing that we see, especially in young people who are having allergic eye disease as well, that affects many parts of their lifestyle. No family history of allergy. Father travels overseas with his work, typically to Malaysia, which is very nearby. And father's noticed that the redness was better when he went to see a private ophthalmologist who gave his daughter some steroids. So the allergy was under control with the topical steroids. He didn't follow up regularly with the private ophthalmologist because the eyes would become white. She then complained of dimming of her vision and came for a second opinion to the glaucoma service. And it was noticed at the time the intraocular pressure in both eyes was 35, and she had posterior subcapsular cataracts. She was started on topical therapy to control the pressure, but due to advanced disc changes, she was unable to reach target IOP. So underwent bilateral trabeculectomies sequentially with mitomycin C. This was her visual field changes at the time of presentation, and you can see very advanced field loss both on the 24-2 and also on the 10-2 visual field. She referred to cornea when I saw her at 15 years old, noted poor vision, underwent bilateral cataract surgery and needling of her bleb. She had topical antihistamine therapy and cyclosporin 4 times a day. When we saw her when she was 18 years old, her best corrected visual acuity now was 612, 6'9", and she's studying in Australia. She's now 24 years old. I just saw her recently. She had a small bleb bleed that was repaired. Intraocular pressure is well controlled at 6 in both eyes, visual acuity at 612. Her VKC is quiescent, and I recently saw her basically about 2 years ago, and now she's being followed up for her allergy and glaucoma, but there's little exacerbation of both of those things for the time being. But you can see here now from her nerve fiber layer analysis and also her field changes over the 12-year follow-up, that even though she has, even despite having good intraocular pressure control, she has some very advanced basically field loss. And at this age, it's unlikely, obviously, through her lifetime, she's going to maintain her vision because of the poor presentation at the initial presentation to us. So VKC can have debilitating effects on the quality of life, especially if obviously children are doing a lot of schoolwork and during basically exam times, and also related to outdoor social activities as well. Even though steroids aren't freely available in Singapore over the counter, people frequently travel, as we all know, throughout the region, and hence they can buy steroids and bring them back for their families and stuff. And we see this also with basically cosmetic contact lenses as well. The generic or the quality of non-generic over-the-counter eye drops can cause secondary allergies. We know that, typically Stevens-Johnson syndrome. And really, there was an urgent treatment to control the inflammation and the IOP in a young child. But we also basically had to do a lot of counseling for the parents to explain the situation, because of course there is a risk of blindness in this child. And initially they actually refused any treatment because they don't want to have any treatment at all, even to control the pressure itself. And there's a lot of guilt, you can imagine, between the parent and the child. And of course, the job prospects for this individual is also limited by the visual field as well. Now I recently saw her, and now she's actually getting married following her education in Australia. So really, there's needed time for change, and the evidence basically comes from these two studies, the vector studies that were performed in Europe, and showed evidence of really changing how we should be managing patients with VKC. So these were multi-center double-masked studies, basically phase 3 studies, which was basically 4 months, and an 8-month double-masked safety study. And the studies were basically using topical cyclosporin as an initial treatment for treating severe VKCs in a pediatric population. This shows you the overview of the study. So period 1 is basically 4 months, and the children were randomized. So 169 children at baseline, randomized to Icovir 4 times a day, twice a day, or basically the control arm, which had the same baseline excipient compared to the other 2 drugs. And then after a 4-month time period, there was an option of staying on basically twice a day, staying on 4 times a day, or the group that were in the control arm were able to be randomized for either twice a day or basically 4 times a day as well. Because of the fact there's no licensed comparator for the ICOS, the idea was to basically use a medication with the same cationic emulsion as the vehicle. So the endpoints for the study were quite interesting. So they looked at basically a composite score at 4 months, and this was based on the amount of keratitis, the need for corticosteroid rescue, because of course this is what we want to basically avoid, and of course the occurrence of basically corneal ulceration. And they then came up with a formula where you have baseline minus basically the baseline at the specific month, and the penalties for basically using rescue medication, and of course having corneal ulceration as well. The secondary endpoints were basically related to VKC symptoms, so photophobia, tearing, itching, and mucus discharge, and they were assessed by basically self-administration and of course the laboratory tests as well. So baseline, you can see there was very little difference between the 3 groups. The age was very similar and slightly predominant in males compared to females, which is what we often see. And the variation in types were really from the mixed form of VKC, the limbal and the tarsal. And you'll see a little bit of association with systemic, but not so common, which is obviously what we know with VKC. So the endpoint was reached at actually 4 months with both the 4 times a day and the twice a day dosing compared to basically emulsion. And if we put this in real terms, there was a 54% improvement in the use of ICOS compared to basically the control arm. ICOS relieved the most symptoms, of course, VKC, so symptomatic improvement in almost 2/3, improvement in photophobia, likewise for tearing, itching, and basically mucus discharge. The rationale, where you compare 4 times a day versus twice a day, again, greater improvement in 4 times a day compared to twice a day, more conclusive statistically in 4 times a day versus basically control arm compared to basically twice a day, much more improvement in the mucus discharge, and basic greater improvement in the quality of life domains as well. So the evidence really for the steroid sparing effect is that the majority of patients did not need corticosteroid rescue among the 4 months randomization period when it was used basically 4 times or basically twice a day. And the mean use of steroid rescue was nearly 50% lower in the ICOS group compared to the control group as well. So it basically shows the steroid sparing effect of this itself. The portion of patients over the course of needed rescue medication was 32% in the ICOS group versus 54% over that initial 4-month period as well. And the number of ICOS patients who required corticosteroid rescue medication remained low over the 12-month time period. So it showed you had a sustained effect over that 12-month time period as well. So it shows in the initial 4-month phase 3 study the importance of basically improving the signs of VKC as assessed by the CFS score. The cyclosporine was associated with improvement in symptoms at every single time point, and improvement in symptoms, corneal damage, and quality of life up to was sustained over the 8-month time period as well. In period 2, from 4 to 8 months, the analysis demonstrated the stability and improvement that we were basically able to see in the first 4-month time period. So really now we're at a situation where there is a paradigm shift in the way we should be treating VKC. And you can see this from this chart from over here from our publication. And you can see that really what's happened is now topical immunosuppressant agents now have replaced short-term pulse steroids as the second-line therapy after basically topical antihistamine or Marcel basically stabilizes. And the reason why this is important is because, of course, you don't want to have any of the side effects of steroids, as we showed in that example in that young child that I basically showed you. Of course, you still need to use topical therapy, which can be difficult, especially with compliance in basically young children. So what we've been doing over the last few years is basically developing a liposomal drug delivery system. And you can see from the in vitro release data here on the left-hand side that you can get sustained release above basically target therapeutic threshold for almost about 7 weeks in vitro. And actually, when the studies were repeated in the rabbit eyes, you showed a much better effect, basically up to 8 weeks in this rabbit conjunctival levels over here. And you can see from the bar charts, the one in green over here is just a concentration of actually topical therapy. So you know you're going to get a waxing and waning effect with basically topical therapy. But with the liposomal preparation, we're able to show you're going to get much more sustained release, both in vitro and basically in vivo as well. We subsequently went on to basically show the effect in allergic experimental model of allergic conjunctivitis, as you can see on the right-hand side. And now we're at the stage of GMP production of the liposome. All the toxicity studies have already basically been done. We have an IRB basically filed as well. And currently now we're just finishing our dossier formulation for HSA, and we're expecting basically approval for use as first in man in basically 2024 as basically a phase 1/phase 2 study. And we hope to basically expand this out to incorporate more centers when we're doing basically phase 2 and basically A or basically B over the maybe in the subsequent future as well. But this is an exciting basically development where we can give the injection for the kids, and it should last basically almost 3 months, giving them sustained release tacrolimus formulation without any of the side effects that we know with stinging that can occur with basically tacrolimus, and the convenience of having to not put any of the additional drops for the eyes. Thank you very much for your attention.
That was from Dr. Jyotbir Mehta. Any comments on the presentation? It was quite a nice in-detail presentation about vernal keratoconjunctivitis.
Yeah, I think that was very nice that he has updated with the interesting randomized control trials. And maybe we can discuss after Jayes's presentation because he also is going to bring a very different perspective. And if both of you can pay attention to the chat box and keep the questions, for the discussion, and if possible, to take those questions as and when required.
Yeah, Dr. Rituja is looking into that. She'll be putting it on the chat box. And I would now take the opportunity of introducing Dr. Jayesh Wazirani. He's the Director of Excel Eye Care in Ahmedabad and a very respected name in ocular surface nationally. His talk is on systemic immunosuppression in VKC. Dr. Jayesh, all yours.
Thank you very much, Dr. Abha. I hope the first slide that I'm showing is visible.
Yes.
Yes, we can see this.
Right. Fine. So this sort of segues nicely into the earlier talk by Dr. Jod Mehta on the overall management of vernal keratoconjunctivitis. I'm specifically going to address when and how to use systemic immunomodulatory therapy for these patients. These are my financial disclosures. None of them have relevance to the subject matter that I'm going to speak on. Right. So first of all, why do we need systemic medication for what is essentially an isolated eye disease or an ocular surface disease? The answer is that ocular allergy is not always innocuous. It can and does have severe and blinding complications in a certain percentage of cases. For instance, if you look at this data, which was compiled from a very large cohort of patients with limbal stem cell deficiency, we found that ocular allergy, and specifically VKC and AKC, were responsible for almost a third of all the documented cases of bilateral limbal stem cell deficiency. So it's not always a very mild innocuous disease. Dr. Mehta also showed what can be the devastating complications of unsupervised and indiscriminate use of topical corticosteroids for this condition. So you need to have something which has a steroid-sparing effect, while at the same time keeps the inflammation quiet. It's also important, as he showed, there are psychological and functional consequences of this disease. A lot of the patients are young children. So we need to have something that is easy to comply with in terms of compliance with medication. You need to either completely eliminate or reduce as much as possible the use of strong steroid eye drops such as prednisolone or fluorometholone. And you need to maintain the eye as quiet for as long as possible and prevent flare of disease which causes tissue damage. So this is the rationale for needing systemic therapy in a few cases. When do we use this? Well, if we look at this step ladder treatment algorithm of allergic eye disease, usually systemic immunomodulatory therapy is indicated towards the top steps. That is when you have either very severe or blinding or refractory kind of eye disease that causes secondary complications, or you have moderate but persistent disease and you have a patient who is a steroid responder, and therefore you cannot keep using steroids for those cases. So severe or blinding disease will have very severe manifestations clinically, and in a large percentage of cases will also have secondary complications in the eye, either due to the disease, such as limbal stem cell deficiency or keratoconus or corneal scarring, shield ulcers, etc. Or they may have complications due to the therapy, which is usually cataracts, glaucoma, etc. So how do we use systemic therapy for this eye disease? A variety of immunosuppressant or immunomodulatory drugs are available for use for systemic conditions as well as for eye diseases such as uveitis. And if you followed the earlier talk carefully, you would have noticed that a major part of the pathogenesis of ocular allergy is mediated by T lymphocytes. And therefore, what we find most useful in the treatment of this disease are calcineurin inhibitors, specifically cyclosporin and tacrolimus. The earlier talk mentioned the use of cyclosporin and tacrolimus topically. What I will be talking about is the use of the same drugs systemically. So this was the pathogenesis of the disease, and this is where we can hit the T lymphocytes, and therefore all the downstream inflammatory mediators and the consequences of inflammation are controlled. There is some literature, there are some isolated case reports and case series of the use of systemic cyclosporin or systemic tacrolimus in the treatment of atopic keratoconjunctivitis. That is ocular allergy, which is associated with either asthma or atopic skin disease or some other kind of atopic condition in the body. And the rationale is that the treatment will take care of the atopic condition in different organ systems. With eye disease, there isn't much literature at all. There is one case report in the IGO a few years back by Dr. Nikhil Gokhale, where he's used systemic cyclosporin. Other than that, there's almost nothing for isolated eye disease. So this is our experience from a single center over the past few years. And I have included the patients where we have follow-up data of a minimum of 6 months after starting systemic therapy. You can see that we have 12 patients who have a follow-up of more than 6 months. And the longest follow-up we have is more than 5 years after starting treatment. And the median follow-up is about more than a year. So what you'll notice here is that all these are adult patients. This is because initially we started using this therapy for adults. We wanted to see the safety and efficacy of these drugs in adult population. Recently, we have also started using these drugs in children under supervision and with appropriate monitoring, but that data set is not part of this presentation. So all of these are patients who have VKC in adulthood. So these are patients who have severe active disease even as adults, not just as children. Only 2 of these patients had either skin or respiratory system symptoms. So a majority of these patients had isolated vernal keratoconjunctivitis, not AKC or any other form of atopy anywhere else in the body. You will also notice that almost all of them had comorbid conditions in the eye. So a lot of them had corneal ectasia, keratoconus. Quite a few had limbal stem cell deficiency. A lot of them had corneal scarring, cataract, and glaucoma. So how do we go about this? We explain the need for systemic therapy, take an informed consent. And these are the drugs that I have been using now for the past 6-7 years. During the first half of that period, I used cyclosporin mainly as a systemic medication. For the past 3 years or so, I have shifted over from cyclosporin to tacrolimus for a few reasons, because tacrolimus is now about as cheap or even a little bit cheaper than systemic cyclosporin with generic versions available. It is also more effective dose for dose. And that is also our experience when we use it topically. So to start with, we give some oral prednisolone, which is tapered over 6 to 8 weeks. By that time, the cyclosporin or tacrolimus has taken over action. So in all of these patients, we were able to achieve completely quiet eyes without any disease activity. And the median time for remission of disease was about 3 months. You can see that in almost an equal number of patients were on cyclosporin and tacrolimus. One patient had to be shifted to mycophenolate because of raised liver enzymes. In the long term, and you'll see that we have data of more than 5 years for our longest follow-up patients. What we've calculated is that these patients tend to have very few fluctuations in inflammatory activity. and we had an relapse-free survival of more than 80%. So you can tell the patient that more than 8 out of 10 times, if you comply with the medication and we see you regularly, there's a good chance that your eye will be quiet without the use of steroid eye drops. So these were the other outcome measures that we looked at, how many of them needed rescue therapy with either oral prednisolone or with strong topical eye drops. So none of them needed either topical prednisolone or fluorometholone over a long-term follow-up. Some of them we did use topical loteprednol for a mild flare-up of surface inflammation. You also need this sometimes when you are using topical tacrolimus. And 3 of the patients intermittently needed some doses of oral prednisolone. So we calculated the activity scores from 0 to 4, which at initiation was about 4 in all patients, and the median score in the long term was 0. 6 of these patients had keratoconus. None of these keratoconus progressed even without any other intervention such as corneal cross-linking. So that's another message that if you can control the ocular allergy well, you don't need to really do cross-linking to control the keratoconus in these patients. The glaucoma is also very well controlled because they did not need topical steroids. One of the patients had a progression of glaucoma and needed glaucoma surgery. And at the last follow-up, 10 out of 12 patients were quiescent. The visual acuity improved considerably in all of these eyes, mainly because once the eye is quiet, you're able to do interventions such as giving them contact lenses or doing cataract surgery or even doing ocular surface reconstructive procedures. There was a transient rise in liver enzymes in 3 of these patients, but nothing that necessitated discontinuation of treatment. One patient had to be switched from cyclosporin to tacrolimus and one from tacrolimus to mycophenolate for safety reasons. One of the patients discontinued therapy because was not following up. 2 of these patients we have actually been able to wean away from therapy as the disease has been quiet. So the key messages from this data set is that for severe and blinding cases of vernal keratoconjunctivitis, systemic immunomodulatory therapy is safe. It is highly effective in achieving and maintaining disease quiescence, and you need relatively low doses. So these doses compared to the doses that you use, for example, for solid organ transplants are a fraction of the doses, and the monitoring is also not that intensive, and it is also very cost effective. There are some practical difficulties. Mainly, the major difficulty is the mindset of the treating clinician because we are not trained to treat the patients with systemic medication. So we have a lack of training or comfort or familiarity. But you need to educate yourself, maybe learn, maybe take some help from other specialists such as immunologists or rheumatologists and work in conjunction with them. It does need a little bit of chair time and patient counseling. And one can say that there's not a lot of evidence for this if you look at it directly for VKC, but there's a lot of tangential evidence. And we are trying to create the evidence base. We are working with the team at Shroff and Dr. Abba to come up with some paper in the near future. So that is my talk. And all of the audience are invited to discussions on this and other topics during the Ocular Surface workshop, which was held annually for the past 10 years or so at LV Prasad Eye Institute, Hyderabad. And this year we intend to do it in September at Ahmedabad in India. So I extend a cordial welcome to all of you for that. And thank you very much for the opportunity to speak.
Thank you, Dr. Jayesh. Yes, this is definitely a very important topic of discussion. And before I ask the question in the chat, Dr. Sangwan, would you just like to give your
Yes, I think yes, this is a very important point that Jais has made. I have been using systemic immunomodulator since 2000, but somehow it never was a priority for me to publish. Now is the right time that we bring this literature and experience into the peer-reviewed literature, so that other people can benefit. And there is another important point that you made is that in patients who are adult or adult onset VKC, this is very important to treat with immunomodulator. Otherwise, they are likely to go into stem cell failure and LSCD. Another study that we had published many years ago from LVP, 30% of our patients with VKC continue to have VKC in adulthood, and those tend to have more severe with stem cell dysfunction. So therefore, the need for us in India and Indian subcontinents, in African continent, Middle East, Bangladesh, all of these patients need, systemic immunomodulation to rescue the ocular surface and improve the quality of life for these patients. I think this is fantastic talk. Thank you, Jayesh.
Thanks.
Yeah, there's a question in the chat for Dr. Jayesh. Was there a significant difference noted between keratoconus progression in patients treated with oral steroids versus those not treated with oral steroids?
Right. So let me answer that by saying that this was not a comparative study that we have done till now. So we've not compared two groups of patients. This is a case series. And as I showed you that in all of these patients, the keratoconus did not progress just by controlling the VKC. In general, that has also been my experience with all patients of ocular allergy, that whatever method you use to control the allergy, topicals or periocular treatment or systemic, if you control the allergy well enough, in a large majority of these patients, you really don't have to do anything much for controlling the progression of keratoconus, because that is basically driven by two things: the inflammatory mediators on the ocular surface as well as the eye rubbing. So by controlling the allergy, you control both of these things. And in my experience, I would not recall even a single patient of ocular allergy where I've had to do corneal cross-linking. So that is, in a way, answers that question.
True,
Yeah,
and
and
I
also cross-linking will be a temporary. If you don't control the inflammation,
Right.
which is driving this, that will be a temporary, and recurrence or progression will happen.
There is also a risk that with active inflammatory disease, if you do any kind of intervention, take the epithelium off, do UV light, etc., you might end up in more problems.
Yes.
True. That's an important message, that if you are intending to, if you see a keratoconus progression and you are intending to do a cross-linking, you need to first have your allergic symptoms under control. Paras ma'am, would you like to add something?
In fact, it was very heartening to, see that all his keratoconus, progression stopped with management. And we all should understand that without controlling the allergy, if we treat these patients for CXL, probably we end up into disasters many a times. These are the ones who would have very bad scarring or can end up with other complications related to CXL. So very well formulated talk, Jesh. Thank you for that. Even I have started using systemic cyclosporin for all my severe VKC patients.
Thank you, Dr. Mehta. Now, our next talk is by Dr. Harminder Dua. He's the Professor of Ophthalmology at Queen's Medical Center, Nottingham, UK, and he'll be speaking on the clinical implication of surface epithelial healing patterns. I am just sharing his talk next. Can you see my screen?
Hello and good day to all. For my friends and colleagues in India, I wish you all a very happy Republic Day. Cells of the limbus reside in the limbal epithelial niche. They step out of the niche as transient amplifying cells which constitute the basal epithelium of the cornea. These divide into postmitotic and terminally differentiated cells. Differentiated cells desquamate, and the rate of desquamation is balanced by the proliferation and multiplication of cells from the limbus. My observations on the clinical patterns of corneal epithelial wound healing began with this index case where there is a large central epithelial defect with an intact limbus. Defects do not heal by forming circles of smaller diameter, but instead, from the remaining intact epithelium, convex sheets of epithelium arise, can vary between 3 and 6 in number. They migrate centripetally, undergo contact inhibition, and form geometric shapes such as a triangle, hexagon, quadrilateral, and pentagon. When they migrate further centripetally and meet, these sheets form contact lines which are Y-shaped. As you see here, a complete double Y-shaped contact line. One Y could be missing, or limbs of the Ys could be missing to give you the pseudodendritic appearance of corneal epithelial wound healing. Here are the convex sheet coming from a circular abrasion. they form this very nice quadrilateral, and when these sheets meet, it forms this Y-shaped contact lines. This lasts for a few hours and then disappears completely. This diagram illustrates how the Y-shaped contact line might form. 4 epithelial sheets moving centripetally would form the long limb and the 2 side limbs above and below, with a large central epithelial defect which healed by the formation of a triangle and the spur of a Y over here. As the top sheets migrate centripetally, it will form a Y-shaped line as you see over here. The important aspect of epithelial wound healing is that the advancing edge of the sheet is not attached to the underlying basement membranes or Bowman's membrane. Fluorescein dye seeps under the edge for a short distance to make the edge very fuzzy. Equally, we see over here that the entire epithelial sheet participates in the healing process. You can see this stippled late fluorescein staining, suggesting that the cells have lost their desmosomal attachments and are all migrating, with fluorescein outlining the cells. And the center of that migratory point is this Y-shaped contact line that has formed by the healing of the abrasion. The abrasion occurs in an exponential manner, initially rapidly and then slowly as it reaches complete healing. We look at abrasions or epithelial defects where the limbus is involved partially and even the adjoining conjunctiva is involved, like in this patient as well. Some interesting patterns emerge. From the remaining intact epithelium, tongue-shaped projections appear on either side. These migrate preferentially circumferentially along the denuded limbus till they meet, and then it becomes like an abrasion with an intact limbus and follows the first set of rules described. Here is an example. As you can see, the circumferential migration progressing along the denuded limbus with these tongue-shaped projections on either side. They migrate circumferentially closer. The conjunctiva heals by centripetal migration of conjunctival epithelium, and when these circumferentially migrating sheets meet, it becomes like an abrasion with an intact limbus. Cornea heals with corneal epithelium, conjunctiva heals with conjunctival epithelium, and normality is restored. Another example, the same circumferential migration till they meet. And very clearly you can see here the limb of the Y, the long limb, and a triangular defect. As that moves in from the side towards the limb, a Y-shaped line will form, which is exactly what happened and illustrated over here, this Y-shaped contact line. So a panel of another case to show that pattern clearly reproducible in case after case. Here are the tongue-shaped projections. They meet, and then the central corneal heals with corneal epithelium and conjunctiva with conjunctival epithelium. In these patients too, we see an exponential pattern of wound healing, but the larger the limbus defect, the longer it takes for the epithelial defect to completely heal. Next important observation, which constitutes the third rule, is that epithelial regeneration can occur in the y-axis, which is in the anterior-posterior axis. This is illustrated in this panel. The patient had total epithelial defect with fluorescein staining of the limbus, cornea, and adjoining conjunctiva. Looking down, we can see this large area of staining, but the very next day, this sheet of epithelium had come from the depths of the remaining tissue anteroposteriorly, and so was this part of the limbus populated, from which the entire surface regeneration wound healing occurred following the rule of a defect with the limbus involved, with the circumferential migration of cells as we see in these pictures. Next rule relates to the role of the conjunctiva in corneal epithelial wound healing. Before the circumferentially migrating tongue-shaped projections of limbal epithelium can meet, the conjunctiva migrates, reaches the limbus and crosses it to afford cover to a variable area of the cornea. This area of conjunctivalized epithelium on the cornea is thin, irregular, attracts blood vessels, and is prone to recurrent erosions. This panel of pictures from one healing eye illustrates this point nicely. We can see this sequentially, the circumferentially migrating tongue-shaped projections here, but notice that the conjunctiva is also migrating centripetally, and again it draws closer to the limbus. There's a wide gap between these projections on either side of the healing limbus. The conjunctiva crosses onto the cornea and affords variable cover to the corneal surface. The end result is an area of the cornea is covered by late staining cells, which are conjunctival epithelial cells on the cornea. Once it all settles, then the junction of the two phenotypes, the corneal and conjunctival phenotypes, is seen by pooling of dye, indicating that the conjunctival epithelial side is thinner, and these bud-like projections that appear along the edge of the corneal epithelium. An example where this limbus and conjunctiva survived, but the conjunctiva here also survived, and as true to form, healing is occurring from the limbus above. The conjunctiva is also migrating towards the limbus, and in fact it crosses the limbus, and you get an admixture of conjunctival and corneal epithelium on the cornea. Part covered by the conjunctival epithelium is irregular and shows late fluorescein staining, which was a consequence of the previous case I showed, and these are other examples where the same kind of healing of the conjunctiva on the cornea had occurred. Conjunctivalization of the cornea can also be seen more subtly in the form of columns of conjunctival epithelium alternating with columns of corneal epithelium, which in turn correspond to the palisades, as we see over here and here, much broader columns, and in this patient again these narrower columns of conjunctival epithelium. We call this columnar keratopathy and is an early sign of stem cell deficiency. Pictures illustrate more advanced cases of conjunctivalization of the cornea. This is the corneal epithelium staining conjunctival epithelium. This small segment of limbus is sustaining a large sheet of corneal epithelium, with the conjunctival epithelium showing late staining and attracting blood vessels. Here again, corneal epithelium, conjunctival epithelium with that bulb-like projections along the junction of the two phenotypes, pooling of dye and blood vessels. Again, in a graft, same appearance of late staining conjunctival epithelium on the graft. Of these observations, certain management principles can be established. For example, in the case I illustrated earlier, one can prevent the conjunctival epithelium from crossing the limbus by repeatedly scraping it off until the circumferential migration of the limbal epithelium is complete, or if it has already crossed the limbus, one can still scrape it off to allow the circumferential migrating sheets to meet and prevent conjunctivalization. This technique is called sequential sector conjunctival epitheliectomy, as it has to be done in one sector and may have to be done every day or every other day. When, on the other hand, the patient presents with conjunctivalization already established, as we see here and here in a patient with Stevens-Johnson syndrome, one can scrape the undesirable conjunctival epithelium away, allow healing to occur from the corneal epithelium below, and you can see the line of junction of the two phenotypes is pushed well across the visual axis, restoring vision in the matter of days. Here is another example of the same principle. The conjunctivalized epithelium was scraped away, allowing healing to occur from the remaining corneal epithelium, and eventually you can see the junction is pushed well outside of the visual axis to restore sight. And this is yet another example where the same principle was applied. All the conjunctival epithelium was removed, healing occurred from the remaining limbal epithelium to give you a pristine cornea. This principle is also very useful in limbal stem cell transplantation. For example, In this patient with a cement burn, after 360-degree peritomy, the fibrovascular pannus was removed and 2 explants of the limbus from the other eye were placed above and below. The donor site, 2 explants on the recipient, and one can see the epithelium from the explants above and below beginning to grow onto the cornea. However, the conjunctival epithelium also is begun to grow centripetally and threatens to cover the cornea. This can be avoided by repeatedly scraping away the conjunctival epithelium and allowing the corneal surface to heal by the explant-derived epithelial cells. This was the end result. The corneal epithelial cells have completed healing of the limbus. The conjunctiva will now be contact inhibited from growing on. The cornea is then covered by limbal-derived epithelium, and what started like this cement burn with a large epithelial defect on the left side becomes nice and clean, as you see over here in the final outcome. The principle of preventing the conjunctiva from growing onto the cornea after limbal transplantation was refined in this technique we developed called amnion-assisted conjunctival epithelial redirection. Diagrammatically, this is the affected eye, the normal eye, 360 peritomy done and the fibrovascular pannus cleared. Then the explants brought in and sutured above and below. An amniotic membrane may or may not be sutured onto the cornea as shown here, but importantly, this other outer membrane is sutured on top of the explants, but the edges are tucked underneath the edge of the conjunctiva. This forces the conjunctival epithelium to grow on the amnion, while the explant epithelium grows under the amnion onto the cornea, keeping the two phenotypes away from each other. Here's an example of a patient with diffuse ocular surface papilloma medically treated to come to this stage with total stem cell deficiency. The AIOS procedure was done with the vacuum dried membrane, which is transparent and you can see through it. Here's the membrane stained with fluorescein, and those are the explants above and below. We can see that the epithelial sheet is growing under the amnion onto the cornea, whereas the conjunctival epithelium is growing on the amnion. And when the amnion was removed, one can see that the cornea is now completely re-epithelialized, and this was the net outcome with a nice clear cornea restored without having to do SSCE. The clinical patterns of corneal epithelial wound healing can be resolved into certain rules. The first rule, with an intact limbus, healing occurs rapidly and normality is completely restored. Where the limbus is involved, first the limbus is repopulated, presumably by some proportion of stem cells as well, before the central cornea heals. Close observation of the limbus is important during healing, as cells can arise in the y-axis from the depths of the area which apparently was involved. Conjunctival epithelium on the cornea is undesirable, but the clear principle is any epithelium is better than no epithelium because this prevents melting of the exposed stroma. When there is partial conjunctivalization, this can be treated with SSCE, and when there is partial epithelial defect, conjunctivalization can be prevented by sequential sector conjunctival epitheliectomy or by the AIOS technique.
Right. So that was a wonderfully illuminating talk by Professor Dua, and I believe we might have him join us on the meeting virtually at around 1 p.m. along with Dr. Jodh Mehta also, probably. So we may take the questions at that time. I can also see in the chat box that there are a few questions on based on my talk on systemic immunomodulatory therapy in VKC, but maybe I'll also answer those questions once the next two talks are over.
Okay, so now in the moving on with the program, the next talk is by Dr. Guillermo Amezcua from, he's a professor at the Baskin Palmer Eye Institute in Florida, and he will be talking to us about cataract surgery in the setting of severe ocular disease. Just be sharing his presentation as well. Is my screen visible?
Yes.
Thank you.
Hi, good morning, good afternoon. This is Dr. Pasqua. I want to thank the organizing committee of the All Indian Ophthalmology Society for inviting me to this virtual conclave meeting. Specifically, Dr. Pirender Sanwan, who was the one who invited me, and today I want to share our experience and some pearls on doing cataract surgery with these patients with ocular surface disease. I have no conflicts of interest with this lecture, and I think it's always important to understand the ocular surface and how important it is that this ocular surface is always working well as a system, and all of this is to protect the health of the corneal epithelium and the conjunctival epithelium. Specifically, the limbus, as we all know, it's the most important player here, and thanks to a healthy limbus, we'll have healthy corneal epithelium, and this will not only help with corneal transparency, but optical quality of vision. And when this is not working well, in many of the diseases that affect the ocular surface will end with limbal stem cell deficiency if not treated properly or not treated rapidly. And limbal stem cell deficiency is something that we want to prevent. But some cases are advanced when they come to us, or even when we try our best, the patients still develop limbal stem cell deficiency. But these patients also develop cataracts, and we have to be prepared in order to proceed with these cases and help the patients. I do a good amount of cataract surgery in patients with uveitis in my practice. After my cornea fellowship, I did a uveitis fellowship, and I think cataract surgery, there's a lot of good studies and good data, prospective data, controlled trials in patients with uveitic cataracts. We don't have that for ocular surface disease, but I kind of like to compare and learn from the cataract surgery in uveitis published data. And I think the most important thing is that we've learned in cataract surgery with patients with uveitis is the importance of the control of the inflammation before the cataract surgery. It is absolutely mandatory that the inflammation is well controlled. Many years ago, it was considered almost forbidden to do cataract surgery in patients with uveitis, and that was because the instruments for microsurgery were not as good as now, microscope, but more importantly, the availability of different presentations of steroids, topical, intravitreal, periocular, intravenous, and other immunomodulator agents that are now available. So I think now, we do cataract surgery in patients with uveitis, in pediatric patients, and even, implant intraocular lenses with good results. And the most recent meta-analysis from the group of John Kempen in Philadelphia shows that if you plan well your cataract surgery in patients with uveitis with controlled inflammations, these patients will do very well. Well, there are some papers on cataract surgery in patients with severe ocular surface disease, but most of them are retrospective cases, anecdotal cases, case reports, case series. But there's not a lot of good prospective meta-analysis data. But it is important to learn from these papers, because this is a field that not many practice, and important to share experience managing these patients. So in the ocular surface, I teach my fellows and my residents. I think at the end is all what matters is to keep the epithelium happy, and there are different ways that the epithelium can be affected, and either through a neurotrophic component, exposure, a chemical burn, a problem with lid function, allergies, etc. So at the end, we want to correct the etiology of what's affecting the ocular surface, so we can then improve the quality of the corneal epithelium. And we all know the different enemies of the ocular surface. And for this lecture, I'm just going to share a few cases of patients with severe ocular surface disease. But just like in any surgery that you're going to do in a patient with severe ocular surface disease, it's very important to have a step-by-step approach and ask ourselves, if the patient ocular surface is well lubricated. If not, what are we going to do to improve that? If there's any mechanical problems that are causing chronic inflammation, because sometimes you try your best to control the inflammation with systemic therapy, but there's still confounding factors within the ocular surface from trichinosis, lid margin keratinization, etc. And then exposure, active cicatricial disease. You need to control that inflammation. This case is a patient with a biopsy proven OCP that came to us partially, and she was treated very well at the beginning, but the patient stopped treatment and moved to Florida. And she came to us with hand motion visions, and I apologize for this, because I presented this slide in a lecture in Latin America, so this is in Spanish. But she had a white cataract in the right eye, and she had a complicated cataract surgery that was done some years ago on the left with poor vision. But you could see how significant inflammation she had around the lids, skin, the meibomian glands. And we started this patient on a myclophenolate and waited a few months, and then planned our surgery. And you can see here something that's very common, and these patients have phonics foreshortenings. Sometimes we're not even able to place a speculum. Here we were lucky that we were able to place a speculum and get decent exposure, but sometimes you have to pass traction sutures through the lid. I use a silk suture in order to give me better exposure. And clear cornea incision is what's mostly recommended. Scleral tunnels sometimes are necessary, but we like to avoid doing a surgery on the conjunctiva if possible. You want to, this patient had synechia, and you want to use whatever you feel more comfortable to have a better exposure. Here, it's interesting because it looks much better than when you're doing the surgery. A lot of these patients have subepithelial fibrosis, and the visibility can be tricky sometimes in the OR. In this case, we were able to see fine, and then you will do the cataract surgery, whatever technique you feel more comfortable. And I was trying to get that lens, just like in uveitic cataracts, trying to get your lens inside the capsular bag. These patients with chronic inflammation have poor tolerance to sulcus lenses. And I always like to check when I have poor visibility with an endoscope, make sure that my capsule is fine. I remove all the cortex and then place the intraocular lens. And just like in any of the surgeries, the cornea doesn't seal very well. These patients are immunosuppressed, so I think it's very important to close everything very well and close all the sutures. And you can see here, after treatment, after cataract surgery, their skin is so much better. The patient's feeling much better. She continues on myclophenolate. She had 2 infusions of rituximab, and she's now wearing a scleral lens in the right eye, and she has a much better vision. Another patient, another classic patient is patient with severe Sjogren's from a severe dry eye from rheumatoid arthritis. This patient also had a Fuchs dystrophy and high intraocular pressure. Glaucoma service referred me this patient. So we decided to start this patient on systemic therapy for the control of the rheumatoid disease, and also on topical therapy with Altera serum tears and insulin drops. She was having recurrent epithelial defects. I'm sorry, this patient, we decided to go together with the glaucoma service, and we did a cataract surgery. And then this is the type of patients, the visibility was not great, and I'm going to pass forward the part of the glaucoma surgery. But here you can see, this patient has a lot of subepithelial fibrosis and, limbal stem cell deficiency, and visibility can be tough in some of these cases. So either I use an endoscope as my second instrument, or I'll have one of my fellows or residents help me through one of the paracentesis incisions. You had a pretty significant cataract, and you want to do the best technique that you feel more comfortable to disassemble that nucleus. And in this case, it was much easier than the other case, because in this case, we know we're going to do an endothelial transplant. So you can phaco a much higher. In the other patients, you don't have that luxury, and you have to you have to be careful with, of course, with your posterior cuff. So this patient is done well. We've done both eyes, and I still follow her. Probably this patient, I've been following her now for 2-3 years. And to finish, this is a patient that had a biopsy negative chronic cicatricial disease. Cataract surgery was done in the other eye without the control of the inflammation, and the result was very bad. And she basically is monocular. So came to me during COVID time. She was on a wheelchair, and this is an example of sometimes you can't put a speculum. You have to use distraction sutures, and you see the surface looks inflamed. This patient had a good amount of control of inflammation. This is from the betadine that we apply, and I do use a significant amount of betadine because these patients are immunosuppressed, and I don't want to have any problems. But again, I use the endoscope. My cataract surgery machine is the Stellaris Elite. I have zero financial interest with this, but I love this machine. We can do retina surgery, you can do anterior segment surgery, and you see, here we're trying to phaco at the iris plane because we don't want to compensate the endothelium. This patient has no endothelial problems, and don't want to create more problems. And again, just like in the other case, confirming you have a lens in the back, and using your endoscope and closing all the sutures. And this patient still follows with me, and we've had significant progress with lenses, and she's able to ambulate. She comes to the appointments on her own, and though she still has limbal stem cell deficiency, the pemphigoid is well, the presumed pemphigoid, the chronic cicatricial conjunctivitis is well controlled. And I think in the interest of time, I'm going to pass to my last case here. This is a patient with limbal stem cell deficiency from aniridia, and she has a central clearing, maybe the 3 central millimeters of the cornea, and she didn't want a keratolimbar allograft or AIOS lead. She works at our hospital. She's one of our assistants and secretaries, and she also didn't want a Boston keratoprosthesis. So she let this cataract continue, and eventually became a mature cataract. So I thought that I was going to be able to do this. Again, she has aniridia, and so the inflammation was not a big problem here, but the limbal stem cell deficiency was a problem. And I thought I was going to be able to, but as I'm trying to do my rexes, I can't see very well, so I end up doing a can open. I close my incisions, and I do a superior approach. I normally operate temporal. And sometimes you have to lose your battles, and I converted this to an extracapsular cataract extraction, and I teach my residents and fellows, that's it's still very important to know this technique now that everything is phaco. It's kind of becoming in this part of the world a lost art, but we remove the lens with the crystalline lens, and we have no iris. So I was not sure if my capsule was okay, so I decided to leave this patient in phakic, and I think that there's no problem leaving patients a phakic, and then address the problem in the future. We close the incision, and then actually this patient with scleral lenses, you can see here the posterior capsule is intact, but we have no iris, and she has a pretty good quality of life with the sclera. It continues to work in our hospital. So I'm going to finish here. I think control of inflammation is very important. You have to optimize your ocular surface. The epithelium is our best friend, so we want to take good care of the corneal and conjunctival epithelium. Careful pre-op, intra-op, and post-operative management is key here. And you have to have proper anesthesia for this patient. These are not the patients you're going to do with topical anesthesia. and mild sedation. You have to prepare for that. I thank you very much for your attention.
That was an important topic of discussion there, and I'm sure we'll have multiple questions on the same. But in the interest of time, I will move on to the next one, and then we'll take all the questions in the end. Is that fine?
Yes.
Yes, absolutely fine.
I'll be sharing Dr. Pinita's talk. Dr. Pinita Prabhaswat is a senior faculty at the University of Mahidol, Thailand, and she'll be talking to us on SLET and her experience with it.
Good afternoon. Thank you for having me in the part of stem cell. Today, I would like to talk about simple limbal epithelial transplantation and its innovation. I have no conflicts of interest. As we already know, that simple limbal epithelial transplantation, or SLET, is the same as CLET in the part of using very small donor-sized tissue. The difference is SLET transplanted donor tissue directly to the cornea without using the lab. The SLET start in India from Professor Virender Sangwan in 2010 and came to Thailand in 2014. However, there have still many questions to answer. To answer all these questions, we designed prospective multi-center study in Thailand, evaluated the efficacy of outcome of the SLET for our SCD using epithelial phenotype detection integrated with clinical manifestation. In 28 eyes of 26 patients in both auto-SLET 11 eyes and living-related auto-SLET 17 eyes. The outcome evaluated by using clinical manifestation combined with confocal microscopy to detect the cell morphology and impression cytology with immunofluorescence staining to detect the cell markers, CK12 for cornea and CK7 for conjunctiva. After SLET, visual acuity was significantly improved. And these slides show the example of auto-SLET of chemical burn. After SLET, cornea clear, cell markers change from CK7 to CK12, and corneal morphology, epithelial morphology change from conjunctival epithelium to corneal epitheliums. This is another case of auto-SLET following by keratoplasty. The epithelial cells still confirmed to be corneal epithelium for both marker and morphology, and the graph survived up to 6 years now, suggested that the only limbal cells at peripheral area could proliferate and maintain the corneal epithelium for many years. Also, again, in living-related auto-SLET of Stevens-Johnson syndrome, also confirmed by clinical manifestation and epithelial phenotype that auto-SLET could maintain the healthy corneal surface up to 5 years now. The corneal button post-SLET also confirmed the smooth surface of multilayer squamous epithelium without goblet cells, and positive CK3 and CK12, and also positive stem cell marker P63 at the basal cell of the epithelium. That's different from the normal cornea, which doesn't have. It also positive tight junction marker and the adhesion molecule markers with mean follow-up 30 months. At second years, survival rate could achieve nearly 90% and 75% at third years, without difference between auto and allo-SLET and total and partial limbal stem cell deficiency. Interestingly, according to the cause of limbal stem cell deficiency, the Stephen was significantly worse than chemical burn. The risk factor for failed SLET was sex, Stephen, absence of multilayer corneal epithelium by IVCM at 6 months. However, there is no evidence by multivariate analysis. Our retrospective study for 14 years in Thailand demonstrates that survival rate of SLED is better than COMET and CLED, and survival rate is 70% at 7 years. According to etiology of our SCD, shows that Stephen was significantly worse outcome, while burn was the best outcome. Focus in Stephen, SLED significantly better than CLED. In summary, SLED is considered as an effective treatment for patients without SCD, without requirements of advanced laboratory and high technology, with more favorable long-term outcome than CLED and COMET. According to etiology, Stephen has the worst prognosis. However, SLED could provide significantly better result than CLED in our study. And I would like to thank you for our team, Syriac Cornea Stem Cell, and thank you for your attention.
So, I guess we do have some time for discussion in the middle before we start with the cases.
Yes.
Yes, either we can have discussion or we can have one or two cases, and when Harminder and Jodh joins, we can have question answer. Depends on your whatever both of you want to do.
Right. Then I think we might just move on to the cases because there's also a session following this and we have to finish in about half an hour. So let's get a couple of cases in. By that time, if Professor Dua and Dr. Mehta have joined, then we can take the questions at that time.
Yeah.
Right. So I think now we have a sequence of cases, clinical cases on ocular surface disorders. First to present would be Dr. Swati Singh, who is faculty in the Department of Oculoplasty, as well as ocular surface, and does a lot of research on lacrimal gland and dry eyes. And I invite her to present her case, please.
Thank you, Dr. Jayesh. I'll share my slide. Are slides visible?
Yes.
Okay. Good afternoon, everyone. I thank Dr. Abha, Dr. Sangwan, and the whole team of AIOS Conclave for this opportunity. And I'll be discussing a case of severe cicatricial entropion in a patient with mucous membrane pemphigoid. So she's a 48-year-old lady who's one-eyed, and she lost one eye in childhood secondary to some infection. And it's an anophthalmic socket on the left side. In the right eye, she has this inflamed conjunctival appearance along with corneal scarring and entropion in the upper eyelid. And her main complaint was reduction of vision associated with watering and irritation for past 6 months. Her visual acuity in the right eye was counting finger at 2 meters. She's diabetic and had a history of treated tuberculous axillary lymphadenitis. This is how her cornea looks like. Has a lot of superficial vascularization along with corneal scarring and diffuse punctate keratopathy along with central area of corneal thinning. If you look at the lid margin, the upper eyelid, everted eyelid, you can see a lot of distichiatic lashes. They are very fine lashes, almost to the tune of 10 to 15 lashes arising from the meibomian gland orifices. Along with there is a patch of keratinization in the central part of the upper eyelid and small part of the medial upper eyelid as well. Tarsal conjunctiva looks inflamed. In the inferior one also, there was a migration of the mucocutaneous junction. You can see that the gland openings of the meibomian glands have been obliterated by the mucosa, and there are distichiatic lashes, less than the upper eyelid, but they were like 6 or 7. On fluorescence staining, you can see the lid margin, this posteriorly migrated mucocutaneous junction, both in the upper and the lower eyelids. So she had right eye chronic cicatrizing conjunctivitis with the likely etiology of MMP. We did conjunctival biopsy and it showed that IgG positive deposition in the basement membrane, and rheumatology consult was taken and she was started on tablet mycophenolate Moftel. Now, what should I do for correcting the eyelids for this patient? If you look at this upper eyelid, you can see 3-4 these big trichiatic lashes and a lot of distichiatic lashes. There is a patchy lid margin keratinization as well. And This is the area where the keratinization was progressing onto the lid viper area. And medially, she has superior symblephrone. And this whole of the eyelid medially is stuck onto the bulbar surface. So traditionally for these patients, the approach had been just recessing the anterior lamella, which eventually fails. Then there were many studies where people have done tarsal rotation of the margin with mucous membrane grafting. Now the tarsal rotation involves incision into the conjunctiva. Okay, the posterior lamella is already scarred in these patients and tarsus is shortened. So if you give an incision through the tarsal plate, you're eventually reducing the height further. Even if you place a graft, there'll be a lot of scarring which will happen and the chances of recurrence are high. So in all of these studies where they have done various eyelid surgeries for correcting the cicatricial entropion, the issue is that the recurrence is taken as a the success is taken as a symptomatic improvement parameters. Like in this study, if you see 100% eyes had trichosis was in 37.5%, but the success is 100%. So all of the studies will have some form of residual trichosis, which says that these patients have a very high recurrence rate, whatever eyelid surgery you do for them. So the technique which we have now recently over the past 1 to 2 years started doing at LVPI is that we split the anterior lamella from the posterior lamella at the gray line and we recess the anterior lamella. Recession means we take it a little further from the lid margin and then you cover that bare area with the help of a mucous membrane graft. So in the current case, as you have seen cicatrization also on the lid margin area, so you will excise that keratinized lid margin area and then place the mucous membrane graft on the anterior surface of tarsus, the margin, and 2 millimeters of the upper tarsal border. I'll show a surgical video, which is not for this case. I'll just shift to the surgical steps. So this lady had a recurrent upper eyelid cicatricial entropion, had undergone lid margin mucous membrane graft already. So we harvested the graft from the upper lip. Here you can see that I'm marking the graft and infiltrating the donor site before starting the eyelid dissection so that the effect of adrenaline comes in. Meanwhile, I'm doing the eyelid part. So you just infiltrate with the help of lignocaine adrenaline combination and then you move on to the eyelid part. Here, this is the upper eyelid. You can see such an irregular surface as well as a small amount of keratinization and all lashes are turned inside. So you word the upper eyelid with the help of 340 silk sutures and then you split the anterior lamella from the posterior lamella using a 50 number blade. After giving an incision, then you dissect the plane with the help of conjunctival scissors. And in this dissection, since these eyes will have a lot of scarring and maybe a previous history of surgery, you should be very careful that you maintain the same plane. You should not lose the plane. So here you can see this is a tarsal plate. So this whole area is a tarsal plate, which is posterior lamella, and this is skin and orbicularis. I have separated the two. And then you give relaxing cuts in the medial and the lateral segment as well, so that the whole lamella is uniformly recessed. It should not that be at the edges, it is still attached to the margin, and the center, the margin has been recessed. So you give relaxing cuts on the medial and lateral side, and this is how it looks like once you have used the So then you use 60 Vicryl suture to anchor this 3 millimeters from the lid margin. And that defect area is then covered with the help of mucous membrane graft. So the graft is debulked and is debulked using the scissors, simple scissors of all the fat and the thick submucosa. And then you suture the graft with the help of 70 or 80 Vicryl sutures to the skin. And the posterior edge you anchor with the help of fibrin glue. There's no need to put sutures onto the posterior edge of the graft. So you can use continuous sutures. This is how the graft looks like. Post-operatively, these will undergo scarring and shortening. So this graft will form the margin. It doesn't look that prominent onto the lid margin area. I'll show you the post-op pictures of the patients. Here I'm using a fibrin glue so that the base of the graft is anchored to the tarsal plate. This is how it looks post-operatively. And if your graft is thin, it doesn't look bulky. This is just 1 week picture follow-up. So you can see a lot of edema in the lid, but that gradually recovers over a period of time. So this is how she looked 6 weeks post-operatively. As she had mucous membrane pemphigoid, we augmented the immunosuppression in the form of steroids. We added the steroids to MMF for a period of 6 weeks. And this is how the lid margin looks, both in upper and lower eyelid after placing a mucous membrane graft. This is her last follow-up of 21 months, where you can see that at presentation, her vision was counting finger at 2 meters, which was improving with close to 2400. But the conjunctiva as well as the cornea has cleared so far significantly after the surgery. You can see that the congestion in the conjunctiva has reduced compared to pre-operative period, and there was no recurrence of dystichiatic lashes also. And now her visual acuity in the right eye is 20 by 100 parts, and she's using pros lenses, and she's comfortable with that. And this is how the lid margin looks like. Now, this is another case using similar technique where you can see that the right eye has sustained chemical injury and there's a severe cicatricial entropion and the edema of the upper eyelid. You cannot, all the lashes are rubbing inside. And we did the same surgery, and this is how it looks post-operatively. So the lashes are away, and you do not see any prominence of the graft in the tarsal plane. And the lid margin is also fairly sharp. You can use this technique for segmental cases also. Like in this case, you see only in the medial and the central part of the upper eyelid. The lateral lashes and the eyelid is absolutely fine. So in these cases, you just need to do a segmental anti-lamellar repositioning and mucous membrane grafting, where you can see this pinkish graft over here. And this is how even the cornea clears far more following the surgery. So in summarize, you should examine the lid margins in detail, look for any signs of lid margin keratinization along with entropion, and you can combine anti-lamellar repositioning with mucous membrane grafting, which takes care of the entropion part as well as cicatrization as well as your keratinization. In mucous membrane pemphigoid patient, you should hike immunosuppressions because any surgery in these patients can lead to reactivation of the disease, and they can come back with a florid congestion and inflammation of the ocular surface. We published our outcomes in Ophthalmic Plastic and Reconstructive Surgery Journal, and you can further read more detail into this. Thank you. I hope I was on time.
Yeah. So thank you, Swati, for a very lucid demonstration of a very elegant technique. I think this surgery helps all of us a lot, those of us who deal with this vexing problem of entropion, particularly in cases post SJS and with pemphigoid, also in some other indications. So it's very, very useful. Thank you very much for demonstrating that and sharing the relevant literature. I can see that Professor Harminder Dua has joined the webinar, and we really enjoyed his talk, which was recorded on epithelial healing patterns. So we welcome Professor Dua to the discussion.
Well, good afternoon and good morning. Thank you.
So a wonderful demonstration of epithelial healing patterns in different conditions and the use of techniques such as ACER and SSC that all of the audience really enjoyed, Professor Dua. We have some questions from the audience. If you can take them. The first question that we have on that talk is, have you noticed or do you have any data on how diabetes affects corneal epithelial healing?
Well, I haven't got any documented data on that, but we know very well that the main problem is the underlying neurotrophia. Corneal nerve changes, particularly peripheral neuropathy type changes, are picked up in the cornea before they even manifest in the legs and the hands and in the body. So that's been well reported. So confocal microscopy helps in picking up very early changes. And then a lot of the problems that come from epithelial instability and therefore increased turnover as the epithelial cells desquamate more rapidly, and then you get even epithelial defects that delayed healing. And the corresponding corollary of that is that we now know that if you use insulin drops in the surface of the eye, it helps very much in the healing of corneal epithelial non-healing defects. So clearly insulin diabetes and metabolism of carbohydrates plays a part in the stability of the epithelium, but it is believed so far is largely due to the nerve pathology.
Right. Thank you. Dr. Sangwan, you have any comments on Dr. Professor Dua's lecture or any insights, or anyone from the panel? Any questions for Professor Dua?
I just enjoy Harminder's talk. Ever since I was a student, I grew up listening to his talks and teachings, and it's always a pleasure. And thank you, Harminder, for joining us and contributing on our Republic Day.
Oh, thank you. Yes, it's a very nice day. Like I said, it's also my wedding anniversary. So
yes, and wish you
I
happy
tell my
wedding
wife I lost my independence on this day.
Right.
Yeah, go ahead, Jess.
Yeah, I was just asking if anyone has any questions for anyone in particular, including Professor Dua or anyone on the panel. Otherwise,
I have a question, Dr.
yes,
Jesh,
please.
for Professor Dua. So do you feel that if we have a diabetic patient who walks in our OPD and is having dry eye disease, then the changes of diabetes will affect the glands as well as the nerve, which will increase or kind of compound the symptomatology of dry eye? And would the structural changes appear before corneal sensitivity changes? Like, would these patients have a more sensitive cornea compared to non-diabetic patients?
Yes, so the structural changes would appear before the actual sensitivity measurement changes can be recorded, and that's partly because our measurement techniques are not so accurate. We have only recently, I believe, I haven't used it, the Brill aesthesiometer, which for the first time records hypersensitivity as well as against hyposensitivity. And you will see there is a lot of redundancy in the corneal nerves, which means we have perhaps got far more than we need. At least we perceive that. And therefore, you have to lose quite a lot of your nerves before physically you can measure reduced sensation. And that's why structural changes appear obvious before you can start measuring the change. And that may be because of a limitation of our methods of measurement. We see not just diabetes in many surgery, particularly cornea transplants, if you're doing full thickness or deep lamellar, that you've cut all the nerves. And then the new nerves that grow are very scanty. They are not as the normal at all. Same after SMILE, same after LASIK. You're cutting a lot of nerves. But the corneal sensations remain normal by our measurements. They drop a bit, and then after 2, 3, 4 weeks, they pick up. In the refractive surgery patients, we've seen that. So there is a disconnect there between the anatomy versus the function. Diabetes and dry eye, of course, is a problem. One key factor is not to forget focus on the actual diabetic status and the patient's diabetic control and his medication and his compliance, because diet, that will make a bigger difference than just putting more drops or more treatments or plugs or whatever to the eye. But that's also very important.
Okay, thank you.
Yeah. I have one comment that just I think Virender will probably have noticed that there are many cases where you see what many meaning I've seen over my experience, at least half a dozen cases where total ocular surface epithelial defect has occurred. There is documented rehealing from the conjunctiva, and you have seen that day on day that the conjunctival epithelium has come. And at the end of the day, you get total corneal phenotype on the cornea from what was conjunctival epithelium growing on the cornea. The limbus, you do confocal, you do impression, has got total limbal stem cell deficiency, but the central cornea regains its normal corneal phenotype of epithelium. So one would call this a transdifferentiation from conjunctiva to corneal epithelium, but this does happen if there is no vascularization. If the vessels come with it, then it doesn't change this in this manner. So there's another reason why I insist on that statement that any epithelium is better than no epithelium?
Absolutely true. Absolutely. And I mean that this I see in chemical burns.
Yeah.
When you see that epithelium, like recently I'm dealing with a patient who was like bilateral chemical burn, and epithelium seems to have healed. Vision is 6/9, but he's very uncomfortable. When you stain it, that corneal epithelium doesn't seem normal, but on slit lamp looks like okay.
Yeah.
And when I do surgery, I'm able to peel off that epithelium. Now we are trying to study that, the phenotype and the markers and gene expression analysis. Hopefully, we will have answer in some time.
Yeah, that's very true. Yes, and I had one comment on Swati's case report, which I'm sure, but that just needs to be re-emphasized, is that these patients, no matter how bad the cornea surface looks, even if there's vascularization, if you give them this RGP scleral lenses, particularly the mini scleral type, they do extremely well in terms of comfort and vision, even with all that scarring. Like they showed, so clearly you sort out the lids and the adhesions and the dry eye problem, but even with dry eyes, they have to constantly put the drop to fill the reservoir behind the lens. But I've got in Stephen Johnson patients, if they can fit the lens, because with the simplifron sometimes you can't fit one, but the mini scleral works very well for comfort and vision.
Yeah, I agree. I think structurally cornea didn't change in this patient also. You will see those scarring and vessels still persist even after eyelid surgery.
Yes.
But the vision improves because they're able to open the eyes better and they have less of irritation on the surface. So that epithelium heals. Thank you.
Yeah, I think
Professor John Mehta has also joined us on the
that's very good.
from Singapore. We welcome him to this discussion. And it was wonderful to have your recorded talk on VKC and the paradigm shifts in the management. So if any of you has any quick questions or insights or comments about his talk, also please go ahead before we go to the next case.
Yeah, he's in the middle of the OT, and we really appreciate Jod for you joining us and in the middle of your OT. I specifically have one question, Jod. You know, there is a feeling, and not only feeling, me, Jayesh, many of us use systemic immunomodulation for severe VKC. What is do you see such patients, or do you use immunomodulation systemic orally?
Yeah, no, that's a good question. I mean, it's always a dilemma, right? When you see them, especially if they're kids as well, then having to give the systemic immune modulator. I think that I think in some situations, there may be no option. I think that immunotherapy is something that has definitely shown some evidence to work, but sometimes it's difficult to get access basically for patients to do that. Some of the new immunomodulated drugs, especially if it's linked to atopic related disease, has been shown to be quite good for ocular surface basically control of inflammation. Dupilumab obviously is the thing that comes to mind. I mean, you can get ocular surface changes from dupilumab itself, but I mean, it seems to be able to control the patients who have bad, severe skin disease as well, associated with their ocular surface signs as well. So I think that, work definitely in that sort of situation, working with an immunotherapist or a dermatologist is vital to basically manage these patients. I mean, one of the problems with the eye-specific treatment is that is compliance. I mean, I think it's quite difficult sometimes for some of these kids, especially with schooling and stuff. Some of the schools won't put the drops in for the kids as well. And trying to get compliance over a consistent time, I think is a significant challenge. And then that, basically will then affect the parents. The parents may not be able to go to work, or they have to work from home. And then, there's a massive knockdown effect in trying to basically give therapy for these children.
Yeah. If I may comment, Joe, good morning from Nottingham. For AKC more than VKC, tacrolimus skin ointment works amazingly well, at least in my neck of the woods, applied locally to the lids. And I used to insist on the patients putting it in the eye. It's a skin cream licensed, but it irritates, it works. And the pharmacy wouldn't prescribe it. So I used to write to be applied to the skin of the lids. And some people then literally did that, and it still worked extremely well without going in the eye. It doesn't work as well for AKC or for vernal as it does for AKC. But even there, it makes a significant difference. And compliance, therefore, will be better because only twice a day of the 0.03% ointment.
Yeah, absolutely. We have the same here. So we do exactly the same as what you said. We used to have a formulation from Japan, which was a topical formulation, I think which was 0.02%. But after we weren't able to get that in, now we basically do exactly what you said with a protoptic cream, skin cream from the main hospital, and that's exactly what we give to our patients as well.
Great.
So we are fortunate that in India we do have 0.03 for ocular application. A couple of questions from our audience on the chat box for Professor Mehta. One, do you feel there's a role for serum IgE levels for VKC cases without any systemic atopy? And two, do you have any comments on the role of sublingual immunotherapy for these patients?
Okay, so sublingual immunotherapy, as far as I know, normally works more effectively in the subgroup of VKC. There is about 20% of patients who do have associated systemic symptoms as well. So in those 20%, I think I can understand why that basically might have worked. But it's not like your atopic group of patients. I mean, that's a different group of patients as well. So I think in the majority, I don't think necessarily it may be so effective. But I think in those 20%, I think it might basically be effective. For serum IgG, I mean, you want to you're looking at monitoring outcome, right? So you want some biomarker basically from the surface. I mean, I didn't talk a lot. I mean, I only had one slide at the end about the study that I showed with the liposomal levels and stuff. But I can tell you that in that study, we're looking at more specific ocular biomarkers as opposed to systemic. We look for systemic toxicity of the drug because, of course, the tacrolimus is going to be given liposomal subconjunctival injection. So we're looking at systemic toxicity or systemic levels of the drug from a safety aspect. And we will do the serum levels. But actually, to be frank, that's more from a research side itself. But from a practical side, I think looking at local inflammatory response will probably give you much better idea with respect to efficacy.
And again, there's one practical point, if I may, with the chairman's permission. What we forget in these patients is there is always, in my experience, a low-grade subclinical infection or increased colonization by the commensals. And that itself causes perpetuation of the inflammation. So if you give them a course of antibiotics, something like azithromycin, long-acting, or at least at night, give them erythromycin ointment, it cuts down the bacterial load and the inflammation due to that. And the symptomatic relief is better if we don't forget the increased colonization with the bacteria in these eyes. And if you do a swab, if you want to, that can also help in confirming that kind of a situation.
Right. So very nice discussion. I believe we might just be able to squeeze in a case or two. We have 5-7 minutes more. So I'd like to invite Dr. Maria Doctor, who is a cornea fellow at the L.V. Prasad Eye Institute, to present her case. And I request the panelists to stay on if they can.
Yes, thank you, Dr. Jayesh. I'll just share my screen. Yeah. I hope my screen is visible.
Visible, Maria.
Yeah. All right. So I'll be presenting a case of corneoscleral patch graft with AIOS for a deeply embedded line plaque. So this is a patient, a 9-year-old male child who had history of right eye injury with tuna about 3 months ago. Locally, he had undergone foreign body removal with an amniotic membrane graft within the first 1 week. However, later the congestion of the eye did not improve, and hence the parents were really worried and came to us at about 3 months. So now when he presented to us, his visual acuity in the right eye was PLPR accurate. And as we can see, there's a large retained line particle which is almost covering half of the cornea, as well as involving the sclera and extending about 4 mm beyond the limbus. Along with that, there is severe congestion of the ocular surface and fibrosis along with symblepharon formation in the inferior as well as superior fornices. The left eye was normal with a visual acuity of 20/20. So now what next for this patient? As we know, the visual acuity is PLPR accurate and there's a large retained line particle embedded. So is this eye even salvageable? Should we just leave it alone, perform only a tarsorrhaphy, perform amniotic membrane graft along with tarsorrhaphy after the foreign body removal, or perform foreign body removal, which could be likely very deep-seated and hence would require a patch graft or a penetrating keratoplasty. And along with that, should we even combine it with AIOS? So these were the questions which we had in mind. And hence we decided to take up the patient for foreign body debridement and kept a tissue also standby if needed for a corneal patch graft or a penetrating keratoplasty. So this line plaque was actually pretty deep, and hence we needed to excise it along with the surrounding sclera. And we needed a graft of around 9 mm freehand trephination of the host was done, and a 10 mm graft was needed. And the graft was actually tried to match to the limbus of the host as much as possible. So as we can see, this is the original host cornea, which was very thinned out and scarred. And this is also evident from the ASOCT which we have here. This is of the host which is extremely thinned out, about 160 micron. And this is the new patch graft which we have placed. So following the surgery, the patient was doing well. And as we can see, these are the AIOS implants which we had taken from the same donor tissue and placed it all over the cornea during the surgery. So this is his 1 week visit when he was doing well, and even at 1 month. At 3 months, his visual acuity improved to 20/100. However, by around 4 months, there were multiple epithelial breakdowns which were noted. And since the eye was now quiet, we decided to take him up for an optical penetrating keratoplasty. And we also decided to combine it with a autoslat at this visit. So this is a patient about 1 month post the surgery when the penetrating graft, optical keratoplasty graft was doing well. And the also autoslat implants were well integrated. And now his further follow-ups are still awaited. Thank you.
Thank you, Maria. That was quite an interesting case and very well managed.
Yeah. We'll move on to, we have one more case and we'll move on to that and then take questions and comments right at the end. So next we have Dr. Rishabh Shah from, who's a cornea fellow at Prof. Charity Eye Hospital, Delhi. So Rishabh, if you're ready, could you please present your case?
Yes, I'll just share my screen. I hope my screen is visible.
Yes.
Yes, go ahead, Rishabh.
Yes, sir. So I'll be presenting the case of a middle-aged Javanese person who presented to us in October 2022. He had history of injury to both the eyes with acid in 2017. He had undergone an osteodontokeratoprosthesis in the left eye, and he had good vision until December 2019 when he developed staphylococcal endophthalmitis in that eye. So at presentation with us, he had a total limbal stem cell deficiency with a superior symblepharon with a visual acuity of 2/60 in the right eye. Whereas in the left eye, the vision was denied pale and the keratoprosthesis was present. So our plan of management was to perform a live related allogenic simple limbal epithelial transplant in the right eye. The limbal biopsy was harvested from a first degree relative who was his brother. So the surgery was uneventful for the recipient as well as the donor. Starting from the day of the surgery, he received 500 milligrams IVMP for 3 days, after which he was shifted to oral prednisolone 50 mg with a weekly taper of 10 milligrams. At the same time, he was also started on cyclosporin and azathioprine. The topical regimen consisted of topical steroids, topical antibiotics, and lubricants. The steroids were tapered weekly. At this point, we also got a baseline blood counts, liver function tests, and kidney function tests. By week 7, he had an uncorrected visual acuity of 6/60. The amniotic membrane was gradually disintegrating. By the first month post-op, he had achieved an epithelialized avascular corneal surface. The vision with contact lenses was at this point was 6/18, which gradually over the period of follow-up improved to 6/9 with contact lenses. After 1 month, we slowed down his tapering regimen from weekly to 3 weekly. The oral topical steroid tapering was also slowed down to 3 weekly taper. The rest of the immunomodulation was continued. This was his picture at the last follow-up at 15 months post the surgery. Right now, he maintains a visual acuity of 6/18 with contact lenses. He has a posterior subcapsular cataract in the right eye, but since he has good functional vision, he decided to opt out of the surgery at this point of time. The topical regimen is for topical loteprednol twice a day. He has continued his immunomodulation of cyclosporin, azathioprine, and diltiazem, and we routinely monitor his blood counts and liver function tests and kidney function tests. So from this case, our points to ponder are the choice between allogenic SLET versus a keratoprosthesis in patients with a bilateral limbus stem cell deficiency. And also the second point that we've already discussed in our session so far is the safety and efficacy of immunomodulators for ophthalmic indications. Thank you.
Thank you, Rishabh. Very nice documentation and very well presented, and a lot of good take-home points for all of us. Any closing questions, comments from anyone on the panel or the audience? We had two wonderful cases presented.
I think very interesting cases, both Maria and Rishabh, very challenging indeed. And do you have any comments, Jodh, before you go back to your surgery?
Yeah, no, very interesting cases and great outcomes on both of them. What I was going to ask was on the first case, I didn't quite catch the first surgery because you had that implantation of the line. Was that surgery that was done? Was that a full thickness graft or was that a lamellar graft?
Yes, sir. It was a full thickness corneoscleral patch graft.
It was a corneoscleral patch graft, okay, because of the embedded of the basically of the lime on the surface there.
Yes, sir. We attempted a lamellar dissection manual.
Yeah.
However, it was actually we had to do a full thickness. Yeah.
Okay. All right. And then then you took then there was an autoslet done on the other eye for the stem cell reconstruction on the surface. Is that correct?
The first surgery we did an AIOS from the same donor. Yeah.
Right.
The second optical we did an auto.
Autoslet. Yeah. Okay. So once you got some epithelialization on the surface and then did autoslet. Okay. That's quite interesting. Okay. And you know and on the second case, what was the vision in the eye when the other eye had the OOKP done in the contralateral eye?
So we do not, the OOKP was done elsewhere, so we do not have documentation for that.
OOKP done, yeah, Jodh, OOKP was done in SNET. So please don't.
No, that's very interesting. No, it's very interesting. Okay, let's see. Okay. Because obviously
must not be a good vision. I was also a bit surprised, but he said, at that time he had a good vision in the MOOKPI for 2 years.
Yeah. I'm just surprised that I'm just surprised the choice of doing OOKP with potential vision in the other eye. That's why. But anyway, yeah.
I think exactly the same point, and I think that is what we can see. See, if there is a wet eye, even if it's bilateral, I think the first AIOS is a better option than an MOOKP, in my view.
Yeah, I agree. I agree with you. Yeah, that's great. Thank you.
So there's just one question on the chat, which we should address. It just says, why take the risk of systemic complications of systemic cyclosporin for a local disease? Would this be only after exhausting all other options? I would request Dr. Sangwan for closing comments on this.
Jayesh, do you want to answer quickly that question, and then I will have closing comments.
It's always about balancing the risks and benefits whenever you take any route towards treating a patient. So I specifically said that systemic therapy is reserved for a very small subset of patients. But for these patients, the benefits are much more than what the perceived risks are. Whenever we use cyclosporin or tacrolimus, we use it very responsibly with all appropriate monitoring and in very low doses compared to what our other colleagues from other specialties use. That is number one. And number two, these are patients where using prednisolone eye drops for a prolonged period of time would be much more dangerous. You can't give supratarsal injections of triamcinolone because these patients in most cases are steroid responders, and you really don't have too many options left. And therefore, yes, systemic medication is very much justified and as actually the treatment of choice for a certain subset of patients. It also helps you do further reconstructive surgeries. Like, for example, you want to do an allogenic transplant. There is a case series from Hyderabad where they've done allo-slet in VKC patients. And for doing even simple things such as cataract surgery, for contact lens fitting, you need to have the eye to be quiet. So that's why it's very important.
So my take on this is for the person who asked the question. I have a patient who I saw in 2002 in LVP with the VKC with partial LSCD was referred to me for doing alloclat at that time. Instead of that, I put him on systemic steroids and systemic cyclosporin. For next 18 years, I could save his both eyes with proper maintenance of systemic cyclosporin, no surgery. So to me, it is very important to understand what is the risk and benefit in a given situation. So with that, I would like to thank both Abha and Jayesh and all the speakers for a wonderful session we had this Republic Day. Special thank to Jodh for joining us in the middle of his surgeries. Thank you, everyone.
If everyone could just switch on their
cameras.
Yeah, cameras, and I'll just take a screenshot.
Yes, Rituja.
Want to add, thank you, Dr. Paras, and thank you for the case as well, because we, in the entire planning and having the cases as backup.
And also all the case presenters and the panelists. So thank you all. Wonderful discussion.
It was a wonderful session.
Thank you, everyone. And in Hall A now, there's a session on prevention of blindness, 2030 Insight.